fit here. 42 looks like it's going to fit. The chap is 64 years old, so you might want to put it 1.5 centimeters above the head center. If you do that, you've got to come up with a stem that has the necessary build-up to prevent it from impinging and dislocating. And that's what we've done here. So that's what it was pre-op, that's what it is post-op, and that's what the socket looks like 5 years down the line. It's still surviving pretty well. So I think the most important thing in our country is to make sure that whatever you put in has the biggest chance of surviving for as long as possible, because only then will the patient be able to have some sort of a symptom-free life after you've done the arthroplasty. Otherwise, as I said to you before, we don't have the provision for patients to be treated free of cost, and already the patients don't want to come to us because they think we are likely to fail, so you will not be able to break that vicious circle. So personally, in this day and age, I don't think there's anybody who's unfit. Once you're fit for surgery, you're fit for any surgery. But our aim should be that they don't need a second surgery early. So longevity should be the key when you perform arthroplasty in India. Thank you.
So, you want to invite me? I invite myself.
We now have the last session before lunch. We'll have Professor Rajesh Malhotra talking about tips and tricks in total hip replacements. We heard him yesterday in the knee unit. No, it's not working.
A very good afternoon. This is the best time to give a talk. Really, everybody is so attentive. It's very nice. Nobody is feeling hungry. And the important thing you must understand is that there are only tips and tricks about two things: the proper component position and soft tissue balancing. I may show you 200 slides, that doesn't matter. What matters is that you have got to have the correct component position and soft tissue balancing. That's most important, which will decide the outcome. Because you must know, when you are doing the operation of the century, which you will be required to do more and more, the number may be up to say 2 million hip arthroplasty within the next 2 years. And you would like to give the patient relief, but always remember, when you choose a patient, and my tip for that is, I want to remind an advice given by Chanley, do the pseudarthrosis test. If a patient has to be forced into a pseudarthrosis because of your failed surgery, he should still be better than what he is today. If you apply this test, no patient will be unhappy, because the salvage operation for a failed hip replacement is pseudarthrosis. So if I look at a patient and see that this patient is still better off with a pseudarthrosis than what he is now, I will go ahead, and that's the correct patient for me. But technically, if you want to see, and that's what you will get if you do a bad surgery. So what is the indication? A painful hip with altered gait not responding to treatment, or a deformed hip which the patient cannot. You know all this. This is the ankylosing spondylitis, or a stiff hip which is stiff in a deformed position so that the patient is not able to walk. So what is a perfect arthroplasty? It should have the perfect component position and soft tissue balance, and that's where I would like to give you a few tips. And that's, must start with the proper measurement, type of the implant, and correct positioning. And templating is the first step. I'm sure you are all conversant with that, but make sure that's what is going to determine how you put your implants. And particularly with the cementless implants, it's very important to do the templating. If you have an external rotation deformity, you must use the opposite hip for templating. If you have the magnification error, put a scale on the side, and then you can always check your assistant to see what he thinks is the size and cross check. Now, the important thing is the position. Now, this is here where I would like to spend a few minutes. How many of you do the lateral posterior approach? Can I see the show of hands? So, a lot majority do lateral posterior approach. You put the patient in the lateral position. Now, that's the time you have to see what's the lumbar lordosis, what is the position of anterior superior iliac spine of the two sides, and when you put the patient's limb on the other limb, what is the limb length discrepancy and what is the level of the knees. Now, if your patient falls forward, is not supported adequately in front, what will happen is you will put your cup in retroversion. One of the tricks for that which everybody uses is to tilt the table to your side. You know, when you are preparing the acetabulum, ask the table to be tilted to your side, and that will partially take care of the tendency of the patient to fall forward if he is not well supported, and will prevent you from putting the cup in retroversion. That is one thing. Second thing is knowing the preoperatively the limb length deformity and then checking it in a lateral position will help you decide, because you have heard repeatedly limb length is a very important thing. The third thing is if there is a lumbar lordosis, that is going to affect the anteversion in which you are going to put the cup. And fourth thing is that if your anterior superior iliac spine is not right above the inferior one, where when you put the patient lateral, just put your fingers on the two ASIS and see that they are right on top of each other. Because if you have, say, an adduction deformity because of which the pelvis has gone up, you should put your cup more vertical than what you would normally, because when the deformity is corrected, the pelvis comes down, your cup will become horizontal. Conversely, if you have an abduction deformity, the pelvis is lower, you put the cup more horizontal, because when this deformity gets corrected and the pelvis comes up, if you have put the cup at 45, it will become 50 or 55. So remember that. You know, you have to keep in mind how this patient is going to be once the deformities are corrected. So that is the positioning of the patient and the position of the component, which is the most important consideration. So when you want to do the surgery, you want to restore the biomechanics, and what is that? You want to put it at the correct center of the rotation, limb length, femoral offset. So how do you decide the center of the rotation? What we all do is that we take a Hohmann and put it near the obturator foramen, and you have a sponge to it so that the assistant who is holding it, his hand is away from the field, doesn't obstruct you. But that gives you the position of the tal, the inferior margin of the cup, and it will also tell you that the real center of rotation is all right if your inferior margin of the cup is matching with that. If you have put the cup too horizontal, you will see that the inferior lip of the cup has gone away from that notch, and if you have put it too vertical, then you will see it will be protruding far lateral than you would like it to be. Similarly, the point you see as a lateral most on the AP film is actually at about 11 o'clock in the left hip and about 1 o'clock in the right hip. So that is the point. If you have templated your cup nicely and you see that where it is with relation to the superolateral extent of the acetabulum, remember that's not what you're seeing in the posterior approach. That is at about 11 o'clock if you are doing the left hip. Now, the other important thing, when you do limb length discrepancy or when you operate, you have to use more than one method to check that your limb length is all right, because it is so important. Our simple technique is that we dislocate the hip, we mark the center of the hip, mark a point on the trochanter, mark a point on the lesser trochanter, and measure the horizontal and the vertical offset. I'm going to talk more about it, but if you understand, I can just skip through the slides and get you to lunch quickly. If you have the vertical offset, which is from lesser trochanter to the center of the hip, if you restore that, you are going to get your limb length very close. But still, if you don't get your limb length right, it could be because you have put the hip center either too high or too low. And that is why you need to reference from the pelvis. So you need a point on the pelvis. After restoring the correct vertical offset, you need a point on the pelvis to tell you that your center of rotation is not too far away. So you could either pass a pin in the ilium, measured from the greater trochanter in the identical position, that's very important, or some people would put a pin in the cotyloid fossa just below. If you put your finger, when you expose and before you dislocate the hip, divide the inferior capsule, put your finger down. Below the head, you will feel on the pelvis, there will be cotyloid fossa. You put in a pin, mark a point on the trochanter, and when you do your trial reduction, see again where you are, and it will give you overall limb length, because you have restored the vertical offset, but that's the femoral side. But what if the hip has been placed too proximally or too distally, and that can be taken care of only this. So this is, all of you know that when you put a longer neck, you increase the vertical offset, but that only is not the important thing. So what you have to do is you have to have a fixed point on the pelvis. Sometimes in a thin patient, it's a very good idea to take a look at the X-ray and you will see what is the level of the lesser trochanter. The lesser trochanter might be at the level above the ischium, it could be at the level of the ischium, and rarely it could be below the ischium. What you are trying to do here is that when you do a trial reduction, you look at the lesser trochanter and see where it is with respect to the ischium. And in a thin patient, it's not very difficult, and it will at least prevent a gross limb length discrepancy. Again, one of the visual checks which you will do. When you put the patient in lateral position, remember that the sole of the limb on top usually should be 1 palm breadth above the sole of the lower limb because of the positioning. So if that's where you have reached, and if the knee levels are normal in the trial reduction, then your limb length is okay. Again, saying that you must try more than one method because it's such an important thing to have a correct limb length and to have the correct biomechanics and correct soft tissue balance. Similarly, we measure the distance from the tip of the trochanter to the center of the head. Now that is the horizontal offset that decides the abductor function. But what if you put the cup too lateral or you put the cup too medial? It changes everything. So when you have templated, when you have done very nicely everything on the horizontal offset side, remember that your abductor function is dependent not only on what you have done on the femoral side but also on the acetabular side, and the same thing as it applies on the limb length. So again, you may have limited options. It has been discussed. You are very lucky if you have a stem which has a lateralized option, which means it has got a more varus neck than the 135 degree which you are normally available with. Otherwise, you will have to use one of the techniques to restore, which I'll just tell you shortly. So you must pay attention to the shape of the acetabulum, coming specifically to the acetabulum, and that could be actually a normal shape. There could be a large superior inferior inferior-medial osteophytes, it could be dysplastic, it could be protrusio, it could be fused hip and acetabular fracture. So what you must make sure first is that you choose the right implant and the right size, and this has been told to you. You know, always look for and remove the inferior-medial osteophytes, see where the tal is, and put in a Homan which is actually right at the fossa. You know about the reaming. Now, important thing for the Indian scenario is whenever you have soft bone, you will be given sharp reamers. Whenever you have hard bone, you will be given blunt reamers. That's a rule of the thumb. Always remember that. So when you have this case, there is a very difficult secondary osteoarthritis, sclerosis, trust your distributor to give you absolutely blunt reamers. Then what to do in this situation? Most of the times you will find that it's the even numbers which are worn out because everybody uses even numbers. So start with the odd numbers. Right? Start with the odd numbers. If you are lucky, you will find that probably they are not so blunt. So go 43, 45, 47. And other thing which I am going to tell you about, which is very important, is about how much to ream, because we have this issue about very poor bone quality. And you might be inside the pelvis before even you know, and there will be some membrane looking at you where you put a finger and you can just, and like Dr. Maria said, he probably can see whether it's the uterus or the intestine. Otherwise, I have not been able to see that. I have not perforated that membrane normally, but then that's a very, very disturbing feeling. Now, we have talked about the transverse acetabular ligament. That is one way to make sure that you're in correct anteversion, although I would say that it's not 100% foolproof. If you have been careful enough to look at the preoperative X-ray and you get what is called a crossover sign, which means that the native acetabulum is retroverted, then you will put the cup in proper position. Will always be a little more bone overhanging in the front and little extra uncovering of the cup posteriorly. Now this is how I want my cup to look. Always remember the acetabulum is not hemispherical, right? So if you have this bit of exposed cup superior-laterally, you are correct. It's good. That means you are on the correct side. If all of it has sunk inside, either you are protrusio or you are undersized. If it is too far outside, then either you have not been able to impact it all the way in, or you are still sitting on the floor osteophytes and you are not gone deep enough. And that is the kind of bone I want to feel forward. You can, in front, you can do anything. You can use a corpse, or you can use an artery, or see something to feel that there is some bone here. Because if you don't have, and if you have a hard or not bearing, and then you can have the psoas impingement, and that's going to trouble the patient quite a lot. What is the end point of reaming? You have been told that it should be fit with the reamer. People have talked about these trial fit. Put in a trial fit. It should not be too tight. It should not be too loose. Everything you should be able to, but important thing for our point of view is you must at all times avoid over reaming. So how much do you ream? This is the answer. You could under ream 1, 2 or 3, or you could over ream 1 or 2, and that's because of such variable pathology and variable bone quality which we find in our setup. If you have a very, very osteoporotic bone, you run the risk of having a loose fit, or you may, and I may tell you, if your cup is loose, the screws are not going to help you. because the cup is grossly loose. Putting 2-3 screws is not going to make it stable, and that's going to be trouble. You ream 1 or 2 millimeter or 3 millimeter depending on how your bone quality is, and you will have to assess it on the table. If you have a very osteoporotic bone, try not to go through the subchondral bone, because suddenly you will find, like I said, you have gone in, and if you try to hammer your cementous, possibly you will be inside the pelvis. So my trick for very osteoporotic bones, which we find in India, is to use a cup which is either made up of porous metal or has got some form of porous metal coating, right? Then just like the new Pinnacle cup, which has got a Griffian coating, that is the kind of coating I would like, or a porous metal cup made completely of porous metal. And for the femoral side, if you use a taper wedge type of stem, that will be very helpful and will get you out of situation without any failures. And you have to overream when the bone is very sclerotic. You may sometimes have to open out the opening by 1 or 2 millimeter particularly. We know that if you have under-reamed a lot and you try to hammer the stem, you could actually fracture hammer the cup, you may actually fracture the acetabulum. So think about that. So this is how you start reaming, this is you change your angle, this is a prepared acetabulum. And the important thing is that, important thing is that when you use the screws, you could cause all these injuries. So how to put these screws and where to put these screws, you will have these cluster holes which will make it very, very important for you. So one small tip is, before you put this kind of cup inside, you could just take a marking pen and mark, put one mark here and one mark here, and so that you know when you are hammering where your screw holes are. Similarly, when you have impacted the trial cup and you are very happy with the position of the trial cup, take a marking pen and mark it on the skin, the direction of the handle, so that on the patient's skin you know this was the direction of my impactor when I put it in. When you take out, put the real cup, just put that thing in the same direction. Similarly, when I position the patient in the lateral position for posterior approach, I just hold the pelvis in between my hands and then I put a line along the midline towards the body axis, and that with a marking pen keeps on showing me the body axis. So when I put my cup in anteversion, I know that I am not retroverted because I have got that reference line which is the body axis, so I always know that I am in the correct anteversion. So that is the issue about this, and then you can use one of these devices. You can do the combined anteversion. This is a combined anteversion test being performed. You know that, I'm sure you have been told about it. And what do you do if you have done the reaming and then you have the trial, it is fine, and then you put the real cup and it's loose. And in this country there's nothing on the shelf. The patient is already paid, the cup is already open. What do you do? If you are clever, just to take a one size smaller reamer, go slightly deeper inside. Don't go through the floor, but try to ream it, say about 1 millimeter deeper, and you'll find that you can fit the same cup which you have already opened and impacted and get away with it. Now, where do we put the screws? This is a very simple thing. Patient is in lateral position. Feel where the anterior iliac spine is. You can know where the ischium is. You put a rod in that direction, and then you can put another rod perpendicular to that, and that's the area where you are going to work, and that's the area where you are relatively safe to put your screws. A few specific situations. Now, when you have a lateralized acetabulum, again, like I said, if you put your cup in a lateralized position, you will increase the offset, and the patient will have trochanteric bursitis and may even have a fracture of the stem, and then you will not get the optimum coverage. So that's what you have to keep in mind. Ream it a bit more. You may have a superior lateral displacement, in which case, if you tend to put your cup more vertical, that's going to lead to more wear. So you'll have to put your cup more horizontal and supplement if it is required. So you can put a low profile cup, or you can put it a little more vertical with the elevated liner. You could put a structural graft, or you could actually slightly medialize the cup and give you coverage superiorly. Now, protrusio is another very special situation. We see it very commonly. What you need to do here is, the offset is reduced because the hip has gone medially. So we want to take the thing out. In these cases, in protrusio, 2 or 3 things must be noticed. Number one, the sciatic nerve is very close. So now very often you'll get a rheumatoid or these conditions where the hip is destroyed in tuberculosis, it's gone in. When you're exposing, the sciatic nerve is very close. So how you avoid damage to sciatic nerve is by slightly internally rotating the limb so that will move it away. That's one thing you do. And second thing is that when you dislocate or when you do a trial reduction, you are increasing the offset. That's the time you may avulse the trochanter, because these bones may be osteoporotic and the hip has been medialized for a while, and when you're taking it out, you may end up avulsing or breaking the trochanter. So just be very careful about the abductor tension and make sure that you are not over lateralizing, and always it is the peripheral fit which is important, and that's what you must aim for, and then you can fill all these grafts. Dr. Maria just told you that it's very nice to all these grafts get very easily and very nicely osseointegrated, and we have actually published that in the Hip International, where we have shown in a large series that all these allografts, which are, or even with the allograft, when they are put in a protrusio defect or a medial defect, are able to incorporate very well. If you have a superior lateral defect, you can use a supplemental graft there. Now inclination is very important. If you have something like this, then you are sunk, because if you put a highly crossing polyethylene, you'll have a rim fracture. If you have ceramic on ceramic, metal on metal, they will all fail with a vertical cup orientation. So I say the vertical cup orientation is the bane of hard and hard bearing, and if you put your cup in too much of anteversion, God help you, because you will dislocate anteriorly. Now if you have a poor quality bone in the acetabulum side, you will always should go for a special cup like I told you. Now this is again a situation which many of you see, and again I would like to spend a couple of minutes here. This is a situation where the patient comes to you with a fused spine, fused hip, has not been walking for a while. The problems here are that the pelvis is flexed, and how do you make that out is, if you look at the coccyx and the upper part of the symphysis, there should be normally 2 finger breadth distance between the two. Now when the pelvis is flexed, this distance is reduced. When the pelvis is extended, that distance is increased. Now what is the implication of a flexed pelvis? The implication of a flexed pelvis is that when you put your acetabular component, you will tend to put it in more anteversion than usual. So and consequently, when you correct these deformities, these patients will dislocate anteriorly. And that's a big problem, particularly with the fact that when they have this externally rotated position, we have demonstrated that they also in the long run get exaggerated anteversion of the femoral neck. So a cup which has been put in excessive anteversion, a femoral neck which is excessively anteverted, is a dangerous combination to have, because here there is no native cup. You are going to ream through this, and you can see the quality of bone here. You are being told, and I will vouch for it, what Dr. Maria said, you will always find some amount of the pulvinar or soft tissue at the floor. But I won't lose any sleep if I put the cup a little bit out rather than too much in, because these are young patients, and when I'm going more and more medially, I'm compromising more bone stock. But then it's always a good feeling to see that pulvinar and know that you are at the right center where it is. But important thing about these fused hip is you could actually take a lateral x-ray if a patient can stand, lateral standing x-ray, so that you see the angle of inclination of the pelvis with the spine, because if the pelvis is flexed, you will have a tendency to put it in excessive anteversion, and you will end up having a patient who will dislocate anteriorly. Quickly, a few things about the femoral component. You have been told that varus is very important. I'll just say 2 things. I think you have been told enough about these things. One is that if you have templated, and when you are putting the stem, you put a stem size smaller than what you templated, possibly you may be in varus, number 1. Number 2, if you have templated and on the table when you are hammering you see that a bigger size is going, think you might have fractured the femur. So if you have templated accurately, a shorter stem means varus position, a bigger stem means that you might have cracked, and you have been told that there is a sclerotic bone. I have seen Dr. Ranawat start with a burr. He would always take a burr for those 30 seconds. I normally don't take it because I think it will sterilize, will make it unsterile for the next case. But you could actually, if you have a burr or anything, you must take out that sclerotic bone from here. And when you cement, this is called antivarus sign, which means that the shoulder of the prosthesis should be under the tip of the trochanter. If you can see the shoulder of the prosthesis medial to the tip of the trochanter, it means you are in varus. There's no doubt about it. So just quickly, and make sure that you go all the way lateral to remove this bone. You could use a burr, whatever you want, but that is what is going to make a difference to this. So this is what I have told you, and then this is your own feeling, your perception when you are hammering, because we have poor quality bones. You hammer it a bit too much, you may land into problem. You may, if you hammer too less or you put an undersized stem, then that can sink post-operatively. And then the thing which I have told you, these are the situations which we very commonly see, and you must be very careful about these. These are the situations which might require the use of a burr, because that will be a useful technique to sort of, because it's very easy to deflect your reamer from here, and or if you try to drill. So make sure that you take care of that bone and you are mentally prepared. Now another thing about the cementless femoral component is when you push it, all of it should go by hand except for the final 4 or 5 millimeters, 4 centimeters. If it goes more than that, you might be undersized. If it is more proud than that with hand, then possibly you are oversized. Just remember that when I push, I'm very happy if up to the flare it has gone by the hand and it is this much of stem which is left, which I have to hammer with my with my instruments. Now low offset, whenever you can have dislocation, tendon bug lurch and increased joint reaction forces. And you can see here, I have seen some of these fracture at the neck, particularly some people who have put some Indian implant. On the other hand, look at this. This trochanter is impinging onto the acetabulum. So this is actually poor offset. So you must think of both the things. Restoring offset is the very, very important technical point about the hip replacement. And then we know that we have neck shaft angle which is different from the implant Dr. Maria told you. So you'll have to do some jugglery. Either you have a company which gives you a lateralized stem, which means a varus stem, so that you can adjust it. Because if my limb length is all right, but the joint is lax, ideal situation is that I put a lateralized stem which makes the soft tissue tighter without changing the limb length. But that doesn't happen if you don't have a variable neck length, in which case if it's a varus, you cut more neck and put a longer neck length of the head. If it is a valgus, always right from the beginning, cut high, try to preserve as much of bone as possible, and then put a short head. And this is about the coxa vera and the coxa valga. So you got your implants inside, now you do a trial reduction. Somebody was asking that, what do you do? Now if I have got my trial component in and I know that my acetabulum is parallel to the tal, the inferior margin is at the fossa, there is some bone anteriorly which I'll remove if it is going to impinge on the component, or I'll trim, and there is little bit of superior lateral cup seen, my femoral component is in, trial component is in, it is fine. The horizontal offset and vertical offset is just as I planned. I put it in and look for stability. Now what do I look for at that time? Number one, I look for the limb length, whether it's equal or not. I look for stability. And how do I look for stability? I do a combined inversion test, number one. Number two is I will just flex, adduct and internally rotate and see that when it is coming out. Now a catch about that is that if you have put an anterior support onto the patient in a lateral position when you are going by posterior approach, make sure that it is not repeatedly coming out because your anterior support is levering it out. It's very commonly it can happen. So make sure that your support is not the one which is pushing the femur out whenever you are going to flex, adduct and internally rotate. I would externally rotate the limb and put a finger between the ischium and the bone femur to know that it is not going to impinge at the ischium in the external rotation, so that it will not dislocate anteriorly. I will abduct it all the way and put a finger and make sure that there is a finger, at least a finger breadth between the tip of the trochanter and the pelvis, so that it does not impinge laterally. And another clue about this is we have these very severe deformities, flexion, adduction, internal rotation, and very often you need an adductor tenotomy. So the question is when to do the adductor tenotomy. I think that's another important tip apart from what you have been told. All these you have been told many times. But let me first complete this. So you can actually just pull the limb in extension and see how much of it is getting pulled out. Not more than half of it should come out. That's a shuck test. You do a Ober's test if you do for iliotibial band tightening. More often than not, if there is a very severe deformity, I can understand if the Ober's test is positive and I will do pie crusting of the iliotibial band. But if in a patient who did not have severe deformity and the Ober test shows that it is very tight iliotibial band, I will revisit the limb length, because more often than not, it is the limb which has been lengthened which has caused this tightness of the iliotibial band. So just like you used to do for poliomyelitis, just do a Ober's test on these patients and see how tight you are. If you are sure about limb length, then you do a pie crusting. If you're not, try a lateralized stem with a shorter head to maintain soft tissue and reduce the limb length. I would look for impingement, like I've told you, in the abduction and the external rotation. And about the adductor tenotomy, most of these hips are step preoperatively. So a lot of people try to do it before surgery. It doesn't work because it's a deformed hip. You will not be able to know the adequacy of your adductor tenotomy because the hip doesn't move. Now, after the surgery, if you do, there's a risk you might make your hip loose because it was excessive soft tissue tension which will drive your components or your position into adduction. It will make it unstable, and if you've done everything, you should have finished all your soft tissue releases when you do your trial reduction. And if you make the patient straight after putting in real implants and do a adductor tenotomy, you might dislocate. To my mind, the best time to do trial reduction, adductor tenotomy is at the time of trial reduction. try to do trial reduction with the shortest head possible if you are going to need adductor tenotomy. Abduct the limb, do an adductor tenotomy, and then see. Many times I'm not able to reduce the trial. So we just put the trunnion into the cup. Put a trial cup or a real cup, put some sponge or gauze piece in that, reduce the trunnion into that, and then try to abduct and see what is tight. With a stab, just cut it, and then that way it ensures that you will not have any surprises after the surgery when you have got this. So another tip which is very important. You were told about the jugglery with the antiversion in the cemented versus uncemented, and you cannot do it. But one thing which can really help you is to have a modular implant, something like SROM, because that is something really fantastic. If I ever did a very complex arthroplasty in my life, I always took SROM because it gives me 3 opportunities to adjust the limb length. I can sink the sleeve or keep it proud. That is one opportunity. I can change the neck length 30, 36, 42, and I can change the height length. So it gives me 3 opportunities to adjust the limb length. It gives me opportunity to adjust the version. It gives me the ability to shorten the femur if I have difficulty in reduction. I'll just divide the femur, push the stem down. I will do the osteotomy, see how much is the overlap, remove it, put the stem, and then that can work as an intramedullary fixation. So this is an example. This is possibly, to my knowledge, the shortest man who was ever operated for hip replacement. He is 110 centimeters, and you can see this is what his hips were, and see on the lateral view, how these deformities are. It's very easy to do with a modular stem. So the tip is, whenever you have complex proximal femur, a deformed proximal femur, think of modular stems. And then about the cementing, all depends on the quality of cementing. Rajesh has already mentioned quite a lot. I don't think that you need to go about it. The important thing about cementing is that you must have the stem plumb in the center with the good column all around. So it all at the end depends on pursuance of excellence. Whatever you are doing, everything before you operate, look at the X-ray carefully, plan carefully, see where I can go wrong, what I need to do right, and then revisit it after the check X-ray has been done to see what has gone wrong. It doesn't matter to criticize your own work. Look at it critically, see what you have done wrongly, so that you won't do it next time. So that is what it all ends to. Thank you very much for your attention.
I think that message is very apt. Plan well and execute well. Shall I have Professor Malhotra here, along with Prithvi, to answer some questions? Just quick questions before you go for lunch. Any questions? Anybody wants to ask them? We will have them back after lunch as well, in case.
No question?
Okay, fine. So we'll meet up after lunch at about 3 o'clock or 3:15, and then we'll have 2 sessions. We've got the session by Surya Narayan, talking about assessing the painful processes, and then I've requested Dr. Mick Pierce to talk about some interesting X-rays. Take you through that. Lovely, thank you.
So you stabilize it, you approach, again posterior, you clean deep the patient, feel for the tip of the decanter. Normally it's 5 finger breadths below the ear edges. So this patient is too fat, his rough approximate is 5 finger breadths there. So that's the tip. Posterior 2/3, anterior 1/3. Yeah, so anterior. This is incision there. You can go with a reasonable incision, about 12 centimeters. Anything below 10 or 9 is MIS, but 12 to 15 is fine to start. Okay, so you go along the shaft, curve backwards, okay, in that direction. I tend to keep 2/3 of the incision below and 1/3 of the incision top. 15 centimeters there, 5 top, 10 below. Okay, it's pretty simple. You've done that, you've gone through the skin, you've gone through the fat, you've gone through the tensification lata, maximus, you've cut off, or you can do a diathermy. Then you abduct it, the muscle become relaxed, put in a Chandlis. Okay, you've now got the femur looking at you, you've got the abductors there, and you've got the rotators there. Now, yes, now you rotate the femur.
This is the way we do it. I really can't comment it.
So you ask your assistant to move the leg like that, and all of a sudden your posterior part of the femur looks at you like that, maybe that angle. Okay? Yes. So that's how you look. You can see it. That's the acetabulum, posterior wall, the trochanter, intertrochanteric notch, and there's rotators there. Take your humans, the picture is something like that. So this is your and you got the medius there, and you got the rotators here. So you take a humans and put a humerus there. Yes, put a humerus there. Separate the plane between the gluteus medius, okay, and the piriformis, as we talked in the morning about making done that. The piriformis now lies here. Leave that. Below those are the gemella and the obturator. Okay. Yes. What I tend to do is I take my humans from there, once you create the plane, pass it between the gemella and the capsule. Okay. So your capsule is still intact, the posterior capsule, until we haven't touched. Take a knife.
After putting the stitch.
You can do it either way. Either way. If you're doing both of them together, if this is not there, then do the same time, the first stage. But if you're doing separately, then if you put a stay suture now, you'll go through the capsule as well. At this point, I cut this, lift it up, put a stay suture.
Which suture you use?
Because I'm not going to suture back.
Which was shown was, I think, it Athibon.
Athibon, yes. Both they suture back. He sutured back. Big doesn't suture.
Be close to the bone at the time of cutting.
Yes, yes.
Close to the bone.
Close. So you've done that, move it off, you got the capsule.
Yes.
Okay. A capsulotomy. So you've got the capsule like that, the head is there, so you do a T-shape. So then you have one leaf here and one leaf there. Okay? Lift it, so you can put a suture there, retract it, and suture there, retract it, like an open book. Okay, all of a sudden you've got the hip looking at you, synovial fluid coming out, suck it out. So now you've got the neck, you've got the head covered by the acetabulum. Rotate it and dislocate it. So it's pretty simple. Now the head's facing you, the nose been taken away by the retractor. Yes, yes. You got the Charles on top. Take your, you've done a templating. You know where the neck cut is because you've got a very poor lesser trochanter. So mark it.
This is lesser trochanter.
Around there. Yes, one finger breadth normally. Yes.
Tip of the trochanter.
Well, I think it's slightly. Now this is decided by your pre-op templating. Okay, that's been decided. But the angle of the cut, you can use this. That gives you yes. That's the angle of the cut. Okay. No, parallel to the neck. Parallel to the neck. Now, if
It is right angle to the neck.
yes, yeah, parallel to the neck. Yeah, right angle. So parallel to this faces a right angle. If you cut it in that direction, you can get to vertical, anti-vertical stem. If you cut it in this direction, you can get to vertical stem. So it's right angles. So cut the neck, take off the head. So now, you can do that now.
Is it okay?
Yeah, this is good. Put the hands there. Put the hands there. Okay, you've done the osteotomy there. Okay, so now you've reached a stage where you've got acetabulum there, cartilage notch there, the capsule around it. You've done a T capsulotomy there. You've got the labrum. Yeah. Your femur currently is lying there. You got to do the if you want to do the acetabulum, you got to take the femur out of the plane. So you take a bone hook, which is a hook like that. Okay. Place it under the trochanter. So you place the bone hook here, lift it up. This is 0, 3, 6, and 9. 12. 12, 3, 6, 9. At 9 o'clock, so you lift it up, you got the capsule there, do a capsulotomy. Small incision. So you lifted this up, 9 o'clock in the left and 3 o'clock in the right. So you lifted it up, you did a small diathermy cut. Take your humans, put it through that. That humans rests on the acetabulum, on the inferior wall. Yes, margin. So rest there. That retracts your femur away. Okay. The femur is now out of the way, and you can see your cup. Vestibule. Then, if you look at the TL, the transverse acetabular ligament, you want to save that. That's your version. So you take the second humerus, the one humerus is there. Second humerus, put it there. So that's 6 o'clock. So this is the cup lying there, the acetabulum. One humerus goes there, the other humerus goes here. Right? Because you don't want to shave this off. If you shave this off when you ream it, you've got your version.
This is just like this.
Yes. Yes.
It is just like this.
Okay, so you've done that, you do acetabulum. So for this exercise, we consider you've done all that. So you've done acetabulum, now you come on to femur. Is that okay? So you've done the acetabulum, I'll do it there. But for the practical purposes, we approached it, I do the acetabulum before, I've done that, put my cup back, now come on to the femur. Take out that humerus, take out this humerus, put a swab inside. Yes, now you got the femur there. You take an elevator, it's a curved elevator, goes like that. Okay, that curved, this is skin, gluteus maximus, the retractor goes over it, goes underneath and lifts it up.
Just like this?
Yes, when you press this, the femur comes out of the womb. The femur is facing you, mark that line. You want to go as lateral as possible.
And this is in the line of this.
This is nice. So if you look at the cross section of the femur, if you can see that, okay, the top end. If you put your stem like that, it's neutral, 0 degrees. If you put your stem like that is internal. Put the stem there, is vertical. Okay, so it's very important.
We have to be parallel with
These two, yes. Now what you want is at the stage, you put one humerus here lifted up, or the retractor, you put the second humerus along the lesser trochanter. That exposes this. It's important for you to see it. And you have to eyeball this angle, this line. This one has to be here. In other words, it can't be like that. Okay, that's neutral.
So this is box.
Yes.
Should I stand in?
Yeah, you could. Sometimes people tend to do a... Sorry?
Repeat this part, maintaining the proper angle.
What I'm saying is...
Rotate it and show.
What I'm saying is... We'll talk about the cup version later, but if you look at the femur, this is the center, okay, of the femur diaphysis. This is the neck. Normally the neck is anteverted, 15-20 degrees. When you put the stem in, this should be sitting in the center there. Okay? If I draw a line between the two, that's a trapezoidal shape. If I draw a line like that, if it sits along this, it's neutral, or the normal version. If I do that, it's gone retroverted. If I do that, it's anteverted. So it's important for you to make sure that your is gone on this plane.
We try to keep it neutral or
This version.
Neutral. If again, it depends. That's a different question. Normally neutral, But if case, as Sanjeev said, is a combined version. If your cup is anti-verted, then I would retrovert this a bit. If the cup is anti-verted, then you retrovert it a bit. 5 degrees. So you can combine it, and it is about 23. But normally keep it neutral. It never go wrong. Okay.
We cannot do like this because it will perforate and your
I'll put it back in the position so you're doing the same as you're doing. Yeah.
People try to align it with the knee.
Yes, you can do that. Yes, you can do that as well. You can do that.
So some people do it with the lesser trochanter.
Yes, this is what lesser trochanter. So you call the lesser trochanter here.
It is 10 to 15 degree anterior to the anti-version. In
The
comparison.
main maintain is parallel to the anterior surface, no, posterior surface of the lesser trochanter.
Yes, pushes the lesser trochanter. Yes. What you're going to say is, if I take a diagram and I draw it more, this is the posterior, this is the interior. Lesser trochanter sits there. So if I take a section through the femur at the top end, this here, if I go to lesser trochanter sits in that plane. In other words, the plane of lesser trochanter and the plane of this plane, there is an angle of about 10 degrees. So if you keep lesser trochanter as your mark, you want to make sure that this is at 10 degrees to lesser trochanter.
10 degree to the lesser trochanter. 10 to 15 degree.
You understand that?
10 degree anterior.
Yes, to the lesser trochanter. But lesser trochanter is posterior. So that is a bit more complex. If you keep it along this, it's neutral. That's what you can see. Yes. This one shot. You can drill as well. Yes.
This one has to be kept for the
Yes.
has to be
I'll start with the ream. We don't have a ream. We don't have a straight one. We don't have a drill. Normally start with the drill because this is pretty sclerotic bone. Yeah. So if I turn
Start
this
with the
around-
drill instead of a box chisel.
Yes, yes. I think the reason is because
Hopefully that can have
yes,
one.
just the top end. Now if I take this around, listen, you see the thing that he's done matches that line. So it's neutral. He hasn't done this, or he hasn't done that. So that's perfect. Okay, that's alignment. That's fine. You don't want to go too far, you fracture that. So now you want to lateralize it. So you take a straight femur, go through the canal. You lateralize your stem as much as you can. Because lateralize means it will be neutral in your AP view. Yes, if you put your stem in that position there,
It is
yeah,
going
you
to
know
be varus. It is not to be done.
if you put it like that, it's valgus. So you're going to go along.
Valgus is slightly.
Yes. Okay, now you take the rasps.
So osteoporotic you can do with
Yes,
this.
you can gradually pass it through yourself. Oh, this is the side index? Yeah, there you go. Let's make it neutral. Come on. In case you're struggling to do it, take this out, you hammer it back out. You can use Chandler's curate to cure out the constant. In other words, it's this, or the alignment. So if I do a section of the proximal femur, these are my cortices. We talked about the classification in the morning. The neck, osteomized neck. This is not cancellous bone. Yes, you curate this out because you want to go as lateral as possible. You want to stand bang in the center. That's what your stem should look like, the AP. So you want to go as lateral. So you can curate this out and make it.
Go down to the cortical bone.
No, you don't have to go cortical. just enough to make it. Cortex will go too far because there's hardly any cortex here, so you take too much of it. Now, there is a difference between cemented and uncemented. Now, if I'm doing cemented, it doesn't matter. You can go bad, you can take it out. You can take it out as you want. If it's uncemented, you can't do that. The reason is, if I take a cross section of the femur, there, this is the cortex. You've got the cancellous bone there, and this. You've got the canal. So I've put my uncemented stem. Okay. Uncemented. Now, if I go wide and I take this out, all of this out, this will toggle. It'll move in this direction. It's free. There's no bone holding it there. So in a uncemented, you don't want to do that. In uncemented, you just follow the rule. Just go sequentially with this. After box hammer, you do sequentially with this. So 1, 0, 1, 2. If it's cemented, you can take this off because that space will take over cement. You can still keep it in the version you want. That's one thing. Same thing with the reamers. If you use a circular reamer, this is good size. Yeah, so you can go right down. It's fine because the thickness of the circle is the same as that. Now, if there's a bigger reamer, which very often we have, and you go right down, so this is fine here because that's thin, it's tapering. Top, it becomes very big. So it becomes a circle on top. You understand? So this is all cancellous bone. That's been reamed. Now you put uncemented stem in that, it won't integrate there.
Bone will not. It will fill with the 5S tissue.
Yes. You understand? So in an uncemented system, you've got to be very careful that you don't go mild, curating it out, reaming it. Rasping is fine. Am I clear? Lateral.
Just lateral to it.
Good? Is it okay? Happy? So we've done this. We've tried to stem without that. This is one of them. The commonest cause of fracture, which you see in a clinical practice, is when my broach, this side of the broach, hits the lesser trochanter or the medial calca. So I put it in, it's not going. As long as this doesn't touch this end, I keep going in. I'm happy. The minute it touches this end here, I should stop because that will fracture this. Okay? And that will cause you to make circular wire and all that stuff. So if you're going, that's why you make it as lateral so that this and this is far off. So go in and it will still go more. It will still go more lateral.
So remove it in lateral or more inside?
Yeah, more lateral and then more inside. Okay. You going further. And once you've done that, it's always good to stop after 4 or 5 shots. The reason is, the bone takes on the stresses, hoop stresses. Once you've hammered them, hoop stresses go out. Okay, the stress from the hammer goes down the shaft and expands the bone. So you want the bone to take the stress and then stress relax. If you keep hammering it, it won't take the stress and fracture. So after 5 times, wait. Then it takes the stress, then go in. Keep your hand. There you go. Well, we know in case you put it in valgus, you're fine. If you put it there, you put it in varus. Yeah, that's good. Yeah. Yeah. Good. Well done. Let's take it. Fine. Put it back. No, it's fine. You can put it back in. Yeah, that's fine. Take the take this out. This is the transfer. That is what we do. So that's what it looks like. So I think it should be in that plane, and it is in that plane, which is good. Okay, it should be at the level of your cut. That's the level of your cut, which is it's well done here. Okay. Yeah, this goes on. So tell me what happens after this. What do you do next? Sorry? You will try. Yeah, of course you got the cup first. Yeah. Yeah. No, what I'm saying is normally we have a no, that's not anti-version. That's the center of the head should be roughly at the left tip of the trochanter. So this is the tip of the trochanter. I don't have a.
Is this a routine measurement you are making?
It's a good measurement. It's a safe measurement. If you have a Langenbach, that's the best. That's always right angle. So you put a Langenbach there, the right angle goes there. Almost matches. It's not bad. Okay.
So you can then alter the neck length accordingly.
Yes. In case it's not going in, when it's still high, you can use a minus thing. Minus head, yeah. Then decrease it. Okay. Happy? So shall we just go through the steps again? Okay, just for you guys to understand. Yes.
If there is any discrepancy in the middle offset
If there's
from the
any,
templating,
yes.
what should we do then?
If there's any discrepancy in the middle offset,
offset.
yeah, you can increase offset. You can see what is middle offset.
It's the distance between the.
Yeah, you have to leave this for time. This is your stem. Okay. I draw a line in the midline. I draw a line at the center of the head. There. This is horizontal offset. Okay.
If you reduce the neck -1, won't the middle of the
If you reduce the neck minus, yes, it will. Yes. See what happens is, why would you do that? You'll only do that if your this cup. So this is your cup. Okay. This is your normal estimate. If your cup is proud, it means you haven't dreamed fully, and your cup sits center head from here comes there. You understand?
Then only you.
Yeah. Then
So that it compensates the.
yes, so you
minus
compensate
head.
that. Your cup is supposed to lie there. Okay? This is where the cup lives, this is where the center of the head should be. But because you haven't reamed the cup properly, whatever
You
reason,
already settled as a
yes,
cup.
yes, you've left as a cup, so therefore you got to decrease this. Or in protusio, you've gone too far in. Yeah, so you middleize it. So you will increase this. Yeah, so you will longer offset. Yes, or you even get necks with offsets which are offsets. Yes, 122, 127.
We are having confusion between this middle offset and vertical.
Oh, fine. Okay. See,
All you-
okay, fine. This is
shortening is there.
okay. This is a hypotenuse. Okay.
Middle offset is
No. This neck is a hypotenuse. Okay. It's a triangle. Okay. You could imagine. So this is a triangle. Hypotenuse, vertical offset, horizontal offset. Okay. So whenever you decrease your neck, it affects both.
yeah, that's what.
Yeah. You know that 2 square, 4 and 4, 8 under root is that.
Yeah.
We know that hypotenuse is x square plus y square under root.
Right angle triangle is.
So if you decrease this, if you go -2 in this, you'll be affecting both. If you go +2, you're affecting both. Let's also be increase or decrease depending on whether you move.
One question. If you are having shortening of length, but you have to increase the middle offset, won't it affect the length more? So assume that the length is less already. You have to increase the length.
You got to lengthen it.
Lengthen it. Yes. And already the shortening is there. And you have to decrease the middle offset also.
You have to
Your middle offset
has to be decreased. Yes.
Then all this is that whether the vertical offset has to be increased and the middle offset has to be increased. You can't do that.
What you then do is you can use modernity. These necks also come in model necks. What is that? Model necks give you 3 degrees of various values: anti-version, retroversion, and neutral, and plus minus. So they give you 9 different possibilities.
So you can assess both vertical offset and middle offset.
Yes. Sorry. Good question. Now suppose you've got a protusio. You've got a unfortunate condition in which This is the ilioischial line, obturator foramen. Okay. Normally there's a gap between the two. Protusio, the poor guy's head is here, and your head sits there. Okay. Yes, osteophytes all there. That's what it is. You can't dislocate it. What do you do? Yes, in situ. In situ. So what do you do is, yes, what it is, you expose the head again through posterior approach. You've got your capsule, one capsule layer there, one capsule layer there. Put your homens there.
Slightly proximal.
On the neck, one homen there. So now you're looking at the hip and you've got the two homens like that. Your assistant sitting there. You've got the two homens. You've got the saw. You make one incision, so you measure the neck, lesser to length, 1 centimeter. One incision there, one saw cut there. The second saw cut is as far in as you can get before touching the ostomy. So you cut there. So you got this cylinder. Put a corkscrew in the cylinder. Get a hold of it. Okay. All of a sudden you got a smaller headline inside that can be taken out again with the corkscrew. Okay. So you've done double osteotomy. You've done a cylindrical osteotomy and then taken out.
If protusio is too much, as was shown in the pictures today, if protusio is too much, as was shown in the picture today, then how to do
You can do a trochanteric osteotomy. You can do a trochanteric osteotomy. No, we don't need this. This is normally guess it. We have a Mick Pierce here, so let him
No,
take
I've
on.
been letting you. You're doing a great job.
Oh,
I've learned so much.
Oh, well, I learned from him. I was his registrar many years ago. So that's
Some people will dream through itself.
yes, you could.
Itself.
Yes.
It's not coming.
Is that we're talking about protusio?
Oh yes.
How do you?
See a lot of protusio here.
Yes. Yes. So in case the thing we can't
If you
dislocate
can't
the
get the
head,
head, yeah, cut in situ, and then you gently ream or just gently break it up. Just take it out. So I normally can
And
get.
again, there is the question of how people will go through.
Yeah, I don't think I've ever had to ream that head. You always can get it out. You free it up at the periphery.
बहुत बड़ा है 18 डी 15 डी की
happy guys?
Thank you, sir.
No worries. We'll do that. We'll swap places.